Matt Greenberg,
Present.
Rob Chapanelli,
Here.
David Kader,
Here.
Evan Eiler? Not yet. Gail Falk,
Present.
Rachel Gades,
Here.
Peter Ireland? Not yet. Suzanne Jones,
I'm here.
Pat King,
Here.
Stephanie Lorenz,
Here.
Ian Odeji,
Present.
Don Philibert,
I'm here.
Judy Scott,
Here.
Margaret Tando. Not yet. Scott Tucker,
Here.
Megan Campbell,
Here.
Kurt Keel,
Present.
Justin Sheng,
Here.
Lauren Lehman, Scott Frenier.
I'm here.
Is Tracy Hayes here?
Yes, I am.
Oh, great. David Hurley
Here.
and that's it. Are there any, there was some guests invited. Are any guests here that I didn't call? Not yet. Okay. I think at least one of them might be joining later.
And I just
Okay.
realized when I lied, Peter Ireland had said that he wasn't going to be here for the February meeting also. So he's for sure is not coming.
That's right.
Okay. Thank you.
Okay, great. Thanks. So I don't see any guests. Do we have any public comment from anybody? Okay. Has everybody had a chance to look over the January 7th minutes?
Move acceptance, Philibert.
Do I have a second?
Second, Scott.
Okay, so I have a motion and a second. Is there any discussion on the meeting minutes? All right, all those in favor of approving the minutes, say aye.
Aye.
Any
Aye.
opposed? Any abstentions or recusals? Okay, minutes are approved. David, administrative update, please.
Sure. I'll start with the renewal period for PAs and anesthesiologist assistants. And that finished up on January 31st. The period was open from the last day of October until the 31st. We had a total of 659 PAs and AAs going into the renewal, 628 PAs and 31 AAs. 64 of the 659 did not submit renewals. As of today, we have 577 active PAs and 33 AAs. And when I talk about these numbers, please don't try to do the math about how many renewed and how many lapsed. The numbers are moving targets because we can lose and gain people apart from the renewal while it's all going on. The bottom line is we lost just under 10% of the total number of these two professions as a result of the renewal that lapsed and have not yet submitted applications. At one time, that would have been a really surprisingly high and concerning number of licensees lost, but in recent years, that seems to be moderate or low. And again, you've probably all heard me say this before. I think the increase in telemedicine and a larger number of licensees who have fewer ties to Vermont, we gain them at a good rate now also. So it's really not such a concern that we are losing that many PAs. And and AAs. And I'll just note that during calendar year 2025, we gained 80 new PAs and 6 new AAs. So if we lost 64, again, it doesn't seem to point at a concerning trend. Any questions about the renewal?
Yeah.
Dawn?
David, this is related, but I think it was on NPR about a week ago. I heard a piece where there's a movement nationally to change the name from physician assistant to physician associates. Have you heard rumblings of that?
A little bit, and I haven't seen anything proposed with that yet. I know that the National Academy of PAs has changed their name, so it's no longer the American Academy of Physician Assistants. It's the American Academy of Physician Associates.
Okay.
And I think Maine is one of the states that has jumped on board with that change. You know, in some respects, it seems sort of a semantic discussion.
Mm-hmm.
I'm concerned whenever I've tried to look into any information about the issues that come up in that discussion, I think that patient understanding is probably one of the biggest concerns, and a lot of people don't understand exactly what a PA is.
Right.
And if we change it all over again, is that just going to make things worse? I don't know.
Okay. Thank you.
And
Suzanne?
I will comment to that. That's been a conversation that's been going on for 30 plus years.
Oh.
I went to Yale way back when, and they were always called the Yale Physician Associate Program. So they were set in that name. Nationally, it has already been changed. There is a wave across the country that it is changing. But the logistics to change it, I think, are huge, because you have to change all the PA, and I'm going to probably get this wrong, the PA Association of the state has to change all the names within its bylaws. And then you have the ripple effect up that you approach the state. It's not an easy thing to do. In the state of Vermont, one of my pet peeves for years is that we were physician assistants with an apostrophe S. I know I'm grammatically picky about certain things, and that finally got changed. But you will see this at some point. May not be for our lifetime, but you will see it being changed.
Okay. Thank you.
Evan?
Yeah, I think that, I don't personally see much difference between assistant and associate. I agree that apostrophe S was pretty awful. I'm more concerned about things like the movement to change CRNAs to nurse anesthesiologists, which I think is really quite confusing. Also, some states have put in rules that if you introduce yourself as doctor and you are not a medical doctor, that you must state that.
Wow.
A doctor of psychology is a doctor, but they don't know anything about your heart. A doctor of some other field is a doctor, but they don't know anything about your heart. And so that you have to state that specifically for the reason that was mentioned. Understanding of patients, of who they're talking to. There are doctorates in social work and so forth, which are good degrees, but it's a different field.
Yeah, sure.
So, Evan, curiously, what of a doctor of nursing? Do they have to distinguish that?
I'm not sure how other states are doing it. I just have heard that there are so many ways that one can be a doctor. And, they're legitimate degrees. It's sort of like the flip side of that is when Jill Biden, who has a doctorate in education, people who didn't get that there are different doctorates were saying, you know, she's a fraud. She's not really a doctor. And, you know, because they were thinking medical doctor. But if you're in a hospital, you should know if you're talking to the social worker or the physician or the PA. You know, it makes a difference. I'm not sure what they're doing with doctorates of nursing.
David Coderre?
Yeah, in the context of this discussion, I guess my question, maybe Suzanne or David can answer it. How many states in the country allow physician associates or physician assistants to practice independently without collaboration?
I know New Hampshire does.
Yeah, there's a limited number. I want to say the number is around 15, but that may be off. I could look it up and tell you next time, or send out an email after the meeting and let you know. Vermont is sort of in the middle ground where we've, you know, moved on from having a requirement for every supervising physician to be documented and to always like it used to be, you had to have a documented supervising physician available anytime you were practicing. And now, as most of you probably realize, it's just a requirement to have the participating physician is the only one that needs to be documented. And that's the one who you have this relationship with, that that you engage in periodic review of cases, and they're your a main touch point, but you know, it recognizes that PAs interact with a lot of other professionals, and they don't necessarily need to have, you know, it might not be appropriate if they have a question about a particular case. They may be reaching out to a specialist rather than their as in the old, using the old terminology, their supervising physician. So now it's more relaxed. So, okay, if there's no more questions about PAs, I know everybody's excited to hear more about the IT project, but it's becoming real now. Almost all the system is complete, and we are moving into the testing mode. We've been doing a lot of testing on like little pieces of it, but now it's been put together, and much of the work to convert data from the existing CABU system and load it into the new environment has been done, so that we're working in the testing environment with real data. And so we have about 6 weeks, a little bit more than 6 weeks to go until our planned go live. And the lots more work to do. And again, I have to say it out loud every time. Thank you so much to the staff, Kelly and Tracy and Ron. This is a tremendous amount of work doing the testing and making sure that every little piece of this, there's a lot of rules built into the system. It's going to be really important that we are able to launch successfully. We have such a narrow slice of time from the end of the PA renewal until the beginning of the time when we need to be licensing the new residents and renewing the resident licenses, because you can't have one leg in each during a time when you're in a renewal. You have to be in one system or the other, and so it's really a lot of pressure on the staff, and I appreciate their focus and effort. One sad note, I don't know how many of you know him, but a longtime board member, Dr. Jack Murray, a Chittenden County pediatrician, passed away recently. He was one of the founding partners in Timberlane Pediatrics, and it seems like half the people in Chittenden County had him as their pediatrician as children, and he is fondly remembered by many board members and staff. And that's it for my admin update.
Hey, David, I had a quick question.
Sure.
Can you just describe quickly what will be the new application or appliquees experience with the new IT system? Is it going to change their experience, like streamline things?
There's going to be a couple ways that it improves the experience, especially for applicants. It's going to, for one, the application process. The application's going to be iterative, and it's a smart application. So, like right now on the physician application, there's something like 142 total numbered items. Many of those become irrelevant depending on the answers that you've given. And so as an applicant goes through, they're only going to be seeing the questions that remain relevant to them. And so it's going to really, that alone is going to shorten the length of the application, the burden and the effort that they need to put in. The other piece is we're creating what's known as APIs, and APIs are automated interfaces that systems talk to one another, and we're doing APIs with the IMLCC and with the FSMB Physician Data Center and FCBS. And so some of the work that is on applicants to arrange for things to be sent to us, different pieces of the verification are now going to be, when they apply it and their application's pending, it will generate a call to the appropriate system and pull some things in. And so it is going to reduce the burden on applicants. And we have a lot of other goals that we're moving toward too. We're going to make, it's not going to be a requirement, but we're going to be offering the option to do online complaints. And we don't want to have any barriers to submitting complaints. So you still will be able to submit hard copy if that's your preference, or to fax it or email it even, but you don't need to do it in the application in the online system. And eventually it's our goal that we're no longer going to have the HISN system and require Kelly to spend a lot of her time duplicating items and putting them into HISN for you all to be able to see. We're going to be able to create accounts for all of you, and we will be the help desk. If you have any, instead of some unknown person in Washington, D.C. or someplace, it's going, we will be the help desk to, if you run into a problem getting into the system, and we will be able to share directly from our own database with all of you, with the assistant AGs as well. We'll have access so that you'll be able to see the documents that are set up for viewing mode for you, just like they are in HISN now. And that's going to be a huge, I think it's going to be more user-friendly for all of you, and it's going to be more efficient for the board.
Thank you. Awesome.
Thanks, David. And Ron, were you separately going to go over the licensing data for 2025?
No,
We've decided to put, go ahead, David.
No, go ahead, Ron. Yeah.
We decided to put it on hold. Well, our team, right? So this happened last year too. We come up with a set of figures, and then we're not really sure they're exactly accurate. So we look at it again, we come up with a different number. Part of what David was describing before with the data, we're trying to organize by calendar year, but with the PAs, for example, they started end of 2025, but have just finished at the end of January. So we all just want to make sure we're on the same page with what numbers we're reporting. So we're
Sure.
still working that out.
Yeah.
Okay.
We want
That
to
sounds good.
re-verify the data. Yeah.
Okay. I skipped over board issues, which I didn't have any other than to say I just wanted to publicly thank Kelly for getting my testimony together and organized yesterday. Much appreciated. So it looks like we have a hearing at 1. We've got 35 minutes. Why don't we try talking about S142? Does that sound okay, David?
Well, I was going to say, Matt, I had requests from some people interested in that to give them an estimate, and when we discussed it, and I said that we'd go into that after the disciplinary hearing, and I estimated that it would be around 115.
That's
And
fine.
So if we could,
is there
go
a different
through some
one
of
we
the
can
others.
discuss now?
Sure. I'll just skip over that one and go down to the test to treat and see how many of those we can get through before 1 o'clock. Does that make sense?
Sounds great.
Okay. And I do, I don't want to forget, it's going to come up on the list, but I do want to make sure to say, Matt, just many of you already heard this while we were waiting for everybody to get online, but Matt did a great job this morning. Well done, Matt. And again, all these legislative hearings you can stream online, and I can send out the links to it, and you can always go, whatever committee it's in, you can always go to their agenda page, and there's a link on the agenda page to their homepage on YouTube, or you can just search it in YouTube, and it comes up pretty easy. If you just put in Vermont Senate Health Welfare, it'll pop right to their page. So the test to treat discussion, which again was mentioned last month, this was one of those items from the Vermont application for the Rural Health Transformation Grants that we received such a large award on. It's $1 billion, I believe. It's broken up into 200 million a year for 5 years, and and in that application it mentioned a plan to look at authorizing test to treat, which refers to allowing pharmacists to prescribe medications for treatment of conditions confirmed using in pharmacy testing. So give a test for whatever type of condition, infection, or disease we're talking about, and then they'd be able to prescribe for that. This has not yet come up, and I firmly believe the way that we're going to see this, there's already a piece in the Vermont law in Title 26 in the pharmacy chapter that allows what's known as clinical practice by pharmacists. And that section creates a framework that says for this clinical pharmacy to happen, there has to be a protocol established, and it has to be approved by the Commissioner of Health before the clinical pharmacy can happen. And there's a laundry list in that section that has items like vaccinations is an example, and there's other limited instances where it's allowed. What's in that laundry list now does not fit in any way test to treat. So they're going to have to add to that laundry list, and then a protocol would have to be proposed and approved by Rick now as the Commissioner of Health for that to actually happen. So there's been nothing put in a bill introduced yet that would cover that. Not to get too much into the weeds here, the laundry list of that pharmacy section it does come up in the OPR bill that has been introduced, but that's where in the vaccination piece, in the subsection that says, you know how you can go to your local drugstore now and get your COVID shot. This is what allows it under the protocol that's been approved. Right now, the way that item in statute is stated, it says for drugs that are approved under the ACIP, the federal immunization approving body, which has lost a lot of its credibility, and states are moving to, including Vermont, moving to create our own evidence-based list of what are approved or recommended vaccinations. And so that language is being changed to take ACIP out and modify it to whatever is going to work now. But it doesn't have anything. So I'm sharing that just as a matter of interest. And I can't say that the laundry list of clinical pharmacy topics is before the legislature now, but I'm going to be keeping my eye on it. If it comes up, I will let you all know. I don't think that we need to have an urgent meeting, that they'd spend a little bit of time on this. And so we don't need to, the bottom line is we don't need to discuss that today. And one reason why I wanted to hold off a little bit was because Peter Ireland was really interested in it, and he sent me an email noting, kind of cryptically some of the areas where he had concerns, and I thought it'd be really good for him to be present for that discussion. So if that's okay, Matt, I'm going to push that one.
I think that makes a lot of sense. Peter had a lot to say on this, and I'd really like him involved in that conversation, and especially if it's not time sensitive at this point.
Yeah. So everybody understands it's, and even if this did come up, and I think that Rick will be really intimately involved in this discussion in the legislature too, because the entire framework puts him at the center of it. If they do change that laundry list, that it's going to be his responsibility as the Commissioner of Health to approve or disapprove it. So, the next item is an act relating to amendments to the scope of practice for optometrists, as it's already come up a couple times, and Matt testified and did such a good job this morning. There's some other great testimony from Dr. Jessica McNally, who's an ophthalmologist who does a lot of surgical procedures and is she's the president of the Ophthalmological Association, right? I think.
Yeah, Vermont chapter.
And there was another physician, ophthalmologist, who does surgical procedures, who was testifying with some specific examples of cases that really, and I found, and of course I'm, preaching to the converted with me, but I found really made a compelling case of some real world examples of why it would not be prudent to allow optometrists to take on this role. But so the board has previously established a position. I don't, Matt, do you feel like we should have the board take this up again and revalidate that or give current members a chance to weigh in on this and see if members do still support the prior position that it's not appropriate? Or
Yeah, so in preparation for my testimony, I did go back and look, and it's come up every year, although mainly the board looked at it pretty intensively in October 2023 through February of 2024. And I'm trying to think of how much turnover we've had on the board since that time about whether people would want to. Well, let me ask this. Is there anybody that wasn't on the board during those time periods that feels like they need more information? And actually, before I even say that, let me take a pause. The issue at hand is there are currently optometrists and ophthalmologists. Optometrists go to a 4-year school. They have a degree. It's a doctorate of optometry. It deals traditionally solely with vision of the eye, corrective vision, glasses, contact lenses, some diseases of the eye, but mainly having to do with vision. Whereas an ophthalmologist is a physician, 4 years of undergrad, 4 years of medical school, and then 4 years of residency plus minus another year or two of fellowship training. They are surgically trained. They're eye surgeons. So their level of training is different. They're much more extensive training in the whole body, because as we know, there are many diseases that present with eye problems. I think all of us think about things like diabetes have eye problems, but you may or may not know that things like Crohn's disease actually has eye complications that go with it. So there's lots of systemic diseases that we think about that we don't really remember have an eye component. And so they deal with a lot more of those things. They do cornea repairs and corneal transplants and lens transplants and all of those kinds of surgical type procedures. And that's historically been the division of what an optometrist does and what an ophthalmologist does. So this bill has come up several times that would allow optometrists with some advanced training, and I'll get back to that in a second, to do a number, I think it's about 10 surgical procedures. Some of these are open surgery, meaning using a scalpel and cutting into the skin, and some of them are laser surgeries, using a laser to cut into the eye. So these are things that have not traditionally been taught in optometry school. My understanding are there are two, after today's lesson, there are 2 optometry schools in the country, one in Kentucky, and I think the other one was Oklahoma, that do teach these to some degree. But most of the optometrists that are learning this are doing so through an added program that generally constitutes 32 hours of classroom plus some lab work, and may or may not involve actually doing the procedure on real human beings. And so the bill suggests a minimum of 2 procedures of each type in order to be allowed to perform this. The main arguments for this have to do with access to care and cost of care. The primary arguments against it are the same 2, plus the concern about quality of care. So that's the very large, broad picture. OPR put together a report, I think initially in 2019. It's a very in-depth report. They said there's no evidence that we should do this now. They basically released the same report with little changes in 2023 saying, well, now we think it's a good idea. So in 2023 and 2024, this board evaluated that data. We had some outside information from Dr. McNally and a few other people. And I think we had somebody from the optometry board come and talk to us too, if I remember correctly. And we came up, we digested the information, and as a board voted to a official position opposing that position. In 2025, we made an informal discussion. Hey, do we need to discuss this again? The answer was no, our position hasn't changed. Last month, we mentioned it very briefly. When I testified today, I went on the basis of those prior decisions, be happy to bring it back and rediscuss again. Although I don't know that there's been that much change in the data. So I guess I'll open it up for any questions. I'd particularly like to hear about people that were not on the board at the time, specifically about whether we need to formally open this up to write a new opinion or consider a new opinion. Anybody have any thoughts? Evan.
I would just like to reiterate our previous position if people are okay with that and if that would help. I personally sent a letter to the people on the committee on this one. I have a family member who had eye surgery a few years ago who there was a complication, and if his ophthalmologist had not acted promptly and managed it, he would have lost sight in that eye. And I think, one of the issues in taking on more responsibilities is you have to either be able to manage it when something goes wrong or have an arrangement with someone else who can do that real fast. And, there are times when that can work, but this sounds like there's no safety net. There's no nothing. So anyway, I wrote a letter. I'd like to reiterate our previous position if people were okay with that.
Great. Thank you, Evan.
Matt, one thing I want to mention, if there's no other board members who have comments, Bob Tortolani raised a point that I haven't heard anybody else bring up, and I thought it was a really great point. And that was, he said he thought we were too focused on only the optometrist and the ophthalmologist, that doing these procedures, whoever's doing it relies on staff support, and that the ophthalmologists have trained and highly experienced staffs that support them, and that it's really just, adding to the idea that if you have an optometrist who's doing these infrequently, they're not going to have the same level of support. And I thought that was a great point.
Any other comments, feedback, questions,
Yeah.
concerns? Don?
Yeah, I just want to say that it strikes me that I haven't been convinced that this addresses access cost, and certainly quality is an ongoing issue. It just seems like a proposed solution to something that has not been well articulated as a problem. So I would agree with Matt and Evan.
And I would agree with you, Don. And I think that came out in the OPR report. They specifically addressed both access and cost. They could not make a decision of whether this would be beneficial or harmful.
Right.
And I think there are arguments on both sides. And so in my testimony, the way I put it, just to explain, was that there are arguments on both sides that basically, in my opinion, nullify the cost argument and the access argument,
Right.
which leaves us with the quality argument.
Right.
Because I think there are arguments that, well, if you're doing procedures outpatient, maybe it'll cost less. But then there's the counter argument that if there is some indication that optometrists may be performing these procedures at a higher rate than ophthalmologists because of their level of experience, and hence you're adding costs.
Right.
And then the same with access. Oh, well, you think if you have more people doing it, then there'd be more available. But honestly, when you look at the global picture of eye care in this state, these surgical procedures are just a fraction.
Mhm.
And I don't know if you've tried to get an appointment with an optometrist lately, but it's like a 6-month wait. And so if they're busy doing surgical procedures,
Right.
because honestly, they pay more. And I'm not saying that that's the reason they want to do them. And I can understand the idea of wanting to broaden your scope. And I'm not bringing this back to a money issue because it's much more complicated. But if you are doing a procedure that's taking an hour, that's probably 2 or 3 less regular eye exams that you can see. And so maybe we're increasing access for a surgical procedure but decreasing overall eye care access. And then
Right.
again,
I agree.
to the
Yeah.
to the quality issue, in that there is a certain number of procedures that you need to do to achieve proficiency, and then a certain number that you need to do routinely to maintain proficiency. And if we have, 3 times the number of people in this state doing the same number of procedures, then you're essentially diluting that proficiency down.
I agree. And lower cost is offset by complications. I mean, cost and quality are so intertwined in this
Exactly.
case.
Exactly. And they were asking, one of the senators very astutely said, well, what is the complication rate? I don't see you presenting any data. And the problem is there is no data.
Right.
This is fairly new. I mean, I think Oklahoma and Kentucky were some of the first states, and I think they were 1998, if I remember from my reading. So it's been around a little while, but the data really isn't there, looking at outcomes. David Coderre?
Yeah, personally, I do not think we have to revisit this issue, but I think for the benefit of the board members who were not members at the time this was discussed, it might be wise to make sure everybody gets a copy of the position paper that we came up with at that point, because it is a bit of a complicated issue. And then if board members wanted to revisit it, we could revisit it as a group.
And I think David sent out the testimony that Rick had from last year that summarized it. And I think the OPR report was attached to that too, which actually has a ton of data in it. The outcomes were not very robust. Judy?
I'm sorry, before Judy goes, I just say,
Go ahead.
While we're talking about, I can send out an email with more information, no requirement for anybody to read it, but if you're interested, I'll send out a bunch of the background information. This has been going on for about 10 years. I'll only go back to about 2021 or so, but we've submitted a number of statements over the years.
I did hear today that there is more push this year than has been seen in years past. Judy?
I'm just wondering if it should happen that the legislature would move forward and would add these 10 procedures to the scope of practice for optometrists, would there be any onus on the legislature to inform the public that they have changed the standard of qualification for people performing those procedures?
I'll give that a no.
So that's not good. That's an enormous problem in my view.
Yeah. And I will say that just because they open it up doesn't mean the optometrists will start doing it. One of the big things that I was hearing is, malpractice insurance. And Stephanie Winters, who is the executive director of the Vermont Medical Society, said that she spoke with one of the large malpractice carriers who already said that they will not insure optometrists for these procedures. So there are making it legal is one thing, putting it in place is another.
Just one observation in that same vein. My impression all along has been this is a major push by the National Optometry Association, but there's a limited number of optometrists in Vermont that are interested in this.
Pat?
Yes, thanks, Matt. My point was just David, so I'll lower my hand. But I can't lower my hand. For some reason, it doesn't work. Sorry.
Okay. Any other discussion on this? Anybody else feel uncomfortable with where we've left this? Anybody feel like they need more information? I think David sending out that info would be great. And I'd be happy to readdress it next month if people read that and decide that, they want to change their mind or at least discuss it again.
Yeah, and we can, whether it's you or me, Matt, we can we can rely on, I mean, if we can say it was discussed again and members were, there was a straw poll of anybody want to revisit this and that the board was comfortable with the position you had put forth.
Okay. Evan?
What is the course of action here? You know, you testified this morning, the hearing was this morning. They're voting next week, most likely, the committee. And then to the full chamber after that. So probably sort of a month-ish.
So, well,
Mm.
yeah, it's hard to say. This was introduced last year. This is the second year of the biennium.
It's the
So it
biennial,
was
yeah.
introduced last year. It went to Senate Gov Ops, which is always a very they're very open to expanding scope of practice for other professions, and they passed it last year, I think in March, and then it went over to Senate Health and Welfare, and they talked about it a little bit but didn't move it, and so now they're dealing with it, and yeah, it's reasonable to expect it might be passed by them in the next week or so, and then assuming it doesn't need to go to any other committee, which I don't believe it would, then it goes to the full Senate to see if it gets passed by the Senate, and then it goes over to House Healthcare.
So
Probably once it goes to the House, if it gets passed.
my question, I guess, then that's more or less what I had in mind, and thank you for the clarification. My question then would be, is there any merit in taking a formal vote to reiterate our previous position? You know, it's a different year, it's a different cast of characters, and notifying the committee of that, since they'll be voting next week.
You know, it couldn't hurt, but I don't know that it really makes a difference. I mean, the most important thing was Matt's
Yeah,
testimony
yeah,
today.
I would think so. Yeah,
Um,
because he speaks for us.
Okay.
That's scary.
We have full confidence.
Thank you. Well, I just used the arguments that everybody else had made, so that made it easy.
okay, so we're getting a little bit close to 1 o'clock. It's
Yeah.
8 up, but if with your permission, Matt, I'm gonna bring up a late addition, which I thank Evan for. Oversight on my part. In preparing my list, I failed to notice that H237 was still pending, another holdover that was introduced last year and was actually passed by the House. It's now in Senate Health and Welfare, and this is a bill that would allow prescribing by doctoral level psychologists. And we had discussed this in the past and opposed this. This is another one that we've been dealing with for 10 years now, probably. And I know that Evan is scheduled to testify as an interested psychiatrist tomorrow, and brought that to my attention. And anybody who'd like to watch that can see it streamed on YouTube. So it's a little bit late for us to try and pull together a position, or we could, I mean, we can talk about that. I don't know what the sense of the group is. And Evan, maybe you want to make some comments about the bill.
Yeah, in terms of is there anything that the board could do? I think there are a couple of options. One is interested people can send their comments. I'll put the people to send them to in the chat. The other is, I think if there were willingness to do that, I would like to vote to reiterate our previous position of opposition. The arguments are similar to some of the other bills in this genre that we've looked at, which are that the medications for psychiatric conditions are not just active in the brain, they're active everywhere in the body. And it's very helpful to have medical or advanced practice nursing training if you're going to be prescribing medications that are active everywhere in the body. In addition, this is about 30 years too late in that the model, when the push for psychologists to be able to prescribe medications first came up, the model was kind of, you go to your regular doctor or PA or NP for your physical health, and then you get referred to a psychiatrist for your mental health, and they prescribe medications and so forth. And that is just not an efficient way to do it. And it isn't really the way that things are done now. The standard is integrated care, in which you're seen in primary care. There's a collaborating psychiatrist, or to be put on hold because George Belcher is here. We pause.
We have a couple minutes yet. You can finish that thought, Evan. Sure.
Oh, okay. To finish out that sentence, at this point, physical and mental health care have to be integrated in order to work. That's now well understood, and it's not efficient to be sending everybody individually to psychiatrists who will do their thing over here in left field and then send them back to you. That co-location, integrated care, integrated medical records is the way to do that. And the psychologist who is the principal proponent of this bill was asked about communicating with electronic medical records, and he said he tried using one, but it was too much trouble, so he stopped. We're 30 years too late. What we need to do is adequately fund integrated care in primary care the way that the Blueprint for Health meant to do, and which is now commonly done in many practices in Vermont, rather than spending a lot of money to create a parallel system of questionable value. There's lots more that I could say, but it's one-ish, so I will stop.
No. Well, thank you, Evan. I have a question for you when we come back, but
sure.
I think
hold that thought.
Yeah, I'll try and remember it. All right. Judge Belcher, thank you for joining us.
Good afternoon, board members. And I see that we're on the record, and we're taking up the matter of INRI Alvin Liptkar. The docket number is MPN 108-0824 before the Vermont Board of Medical Practice on February 4th, 2026. And I would ask whether Kurt Kuehl is with us.
I am here, Judge.
All right. And how about Devin McKnight? He was attorney for the respondent.
Yes, no, I spoke with Mr. McKnight, and he advised me that neither him nor Dr. Iftikhar would be appearing today.
All right. So this case is coming from the North Investigative Committee, and I'm going to understand that the roll that was called when the meeting started includes the members that are participating in this matter, with the exception of the North Committee. And so with that understanding, and when we get to a motion, if there is a motion, if someone needs to recuse or abstain, they can say that at that time. So, Mr. Kuehl, are you ready to present this?
I am, yes. Thank you, Judge. Yes, so the board opened this matter investigation after receiving a complaint in August of 2024 from a nurse who worked with Dr. Iftikhar at Southwestern Vermont Medical Center. And she stated in her complaint that she had observed Dr. Iftikhar exhibiting behaviors at work that were out of character and which indicated that he may be under the influence of cocaine or stimulants. The complainant also noted that Dr. Iftikhar had been involved in a single car accident in New York at a time when he was scheduled to be at work, and that he was criminally charged with possession of cocaine and driving under the influence. He was ultimately convicted of driving while impaired. The committee's investigation determined that on the morning of July 28th of 2024, Dr. Iftikhar was involved in a single car accident in Hoosick, New York, at a time when he was scheduled to be at work. A couple of weeks later, on August 7th, 2024, Dr. Iftikhar resigned from the Southwestern Vermont Medical Center. The committee also determined that Dr. Iftikhar's health problems affected his behavior and functioning at work and impaired his judgment, focus, and interaction with others. In September of 24, Dr. Iftikhar began working with the Vermont Practitioner Health Program to address his health concerns. And as part of that, he attended an intensive inpatient care at the Care and Treatment Center, which was followed by intensive outpatient treatment at the St. Peter's Addiction and Recovery Center Professionals Program. He engaged in those in January, February, and March of 2025. At the beginning of on January 1st, 2025, Dr. Iftikhar entered into a cessation of practice agreement. And because his license had lapsed on November 30th of 2024, the cessation agreement provided or required that he be granted relief from it before he could apply to renew his license. So he's currently unlicensed at this time. Dr. Iftikhar entered into a 5-year monitoring contract with VIPHIP that became effective on June 1st of 2025. Dr. Iftikhar cooperated with the investigation and conceded that his habitual or excessive use or abuse of drugs, alcohol, or other substances impaired his ability to practice medicine in violation of 26 VSA section 1354A5. After concluding its investigation, the committee concluded that an appropriate sanction for Dr. Iftikhar would be to reprimand him for his conduct and to condition his license, requiring that he participate in care, treatment, and monitoring under the auspices of VIPHIP for a 5-year period of time that began on June 1st of 2025. In addition, the stipulation requires that Dr. Iftikhar appear before the committee to address his compliance with his VIPHIP contract, his progress in treatment, and other matters concerning his practice upon the request of the committee. And finally, the stipulation, if approved, would relieve Dr. Iftikhar of his cessation of practice agreement and enable him to seek renewal of his license. If anyone has any questions, I would be glad to address them.
Other questions for Mr. Kuehl?
Thanks, Kurt.
So I have just one brief question. If his license has lapsed, he would need to apply for renewal in order to get his license in Vermont back. Is that right?
That is correct, yes.
And when he would do that, there would be some scrutiny as to whether he was in compliance with the contract and all that?
Yes, there would be by the licensing committee. I would note that the investigative committee did inquire of VIPIP about his compliance with the contract, and VIPIP wrote a letter in October of 2025 and said that at that time he had been in full compliance, that his use was in remission, and that they believed that he was safe to resume practicing.
I see. Thank you. Any board member questions again for Mr. Kuehl? If there are no questions, is there a motion concerning the proposed stipulation and consent order?
So moved. Stephanie Lorenz.
Thank you. And is there a second?
Second, Ian.
All right. So the motion's been moved and seconded. Is there any discussion about this? Hearing no request for discussion, we'll call the roll on the motion. And Ron, I wonder if you could call the roll of the members of the board accepting the North Committee.
Yes. So members of Central and South are Matt Greenberg,
Yes.
Rob Chapinelli,
Yes.
David Kader,
Yes.
Gail Falk,
Yes.
Rachel Gades,
Yes.
Suzanne Jones,
Yes.
Stephanie Lorenz,
Yes.
Ian Odeji,
Yes.
and Scott Tucker. Scott
Mr. Tucker, are you with us?
I think we lost Scott's connection.
He's muted.
I see him.
I
Yeah,
see
he's
him there.
moving.
Oh, he's on second.
Scott, we're looking for your vote. Scott Tucker. Thank you.
Okay.
Did he give a thumbs up? I didn't see that.
Yes, he did.
He did.
All right. All right. Any members that we neglected? All right, then the vote is unanimous, and the proposed order was attached to the STIP and for Dr. Greenberg's signature. And unless there's something further concerning that matter, that concludes that matter. Great. Thank you, board members. Have a good day.
Thank you.
Thank
Thank
you.
you,
George.
Thank
Yeah.
you.
Okay, we are back. Thank you, Kurt. So Evan, I had a question regarding the last. Could you remind us if there is any stipulation on the medications that are included, or is it all comers? And also if there are any age exclusions, meaning, does this include
Yeah.
pediatric patients, et cetera?
Yeah. The guardrails are by age rather than class of psychiatric medication. It excludes patients under 18 or over 80, which I think is just window dressing. Physiology starts changing in older adulthood much younger than age 80. But yes, there are those.
And no restrictions, so I could be giving clonidine and other medications, that are used for psychiatric purposes but are not primarily psychiatric, et cetera.
Yeah, I'm pretty sure. I'll have to double check on like, could you use alpha and beta blockers,
Right.
Which is where you're going with that.
Yeah,
I'll have
exactly.
to double check the exact wording, but I think that yes, you could.
Wow.
In fact, I
Evan.
can pull that up and check.
So, Evan, this is just a quick question, just for my knowledge. So, with regards to psychiatrists and a clinical psychologist, in terms of management of patients, do they manage different kinds of patients, or are they like similar?
There is some overlap in what we do. For sort of point of reference, my own background is that I did family medicine for 16 years, and the last few years of that, I was a graduate student in psychology. Although I did not complete the degree, I decided it would be better to do a psychiatric residency, and I did that instead. So I have had sort of a foot in the relevant worlds. Both psychiatrists and doctoral level psychologists do a lot of diagnostic work that's quite similar. Psychologists in general have a greater depth in certain types of evaluative testing. So that, for example, I recently saw someone who I thought might be on the autism spectrum in addition to the complaints that she came to me with. I referred her to a colleague who's a psychologist who specializes in neurodiversity, who did a more in-depth evaluation. So, and both do psychotherapy, although usually psychologists may have sort of expertise in some aspects of psychotherapy that psychiatrists tend not to pursue. And then psychiatrists do the things that have to do with the medical side of the field. The consultations in medically ill patients, where you're not just looking for why is this person anxious, but the interplay between mental illness and physical health conditions. We're the ones who prescribe medications, that sort of thing. So there's an area of overlap, but the training is quite different. And psychology graduate school is not very medically oriented. So the idea is that there would be this supplemental training, which is not all that extensive, in my opinion, and then they would add medications to what they were already doing. It looks to me as though it would be preparing people to sort of see the simplest cases in medically well people, which would not provide an advantage since that's already well within the realm of primary care. I also don't think it's worth spending the money to create a whole other licensing system for a whole other genre of people when we're not adequately funding integrated care in medical offices as it stands.
So, and this is the last question. So, can a clinical psychologist manage a schizophrenic patient, or they send that to the psychiatrist?
So far, patients with psychotic illnesses like schizophrenia usually receive multidisciplinary care, so that their medications would usually be managed by a psychiatrist, a psychiatric PA, a psychiatric nurse practitioner. They would also often have, people with schizophrenia may be very high functioning, but most are not, and most are quite unwell. So they might also have a case manager who would be a social worker who would help with practical aspects. They might, if they were well enough to participate in psychotherapy, they might also have a psychologist who helped with psychotherapy along, adjustment, interpersonal skills, etc. But their antipsychotic medication would be managed by a physician, a PA, an advanced practice nurse in general.
Thanks a lot.
Suzanne?
So in the proposal, how would a psychologist order any labs that are needed to monitor, or an EKG to look for prolonged QT? I mean, how?
Yeah, as I understand it, and David, please jump in if I'm getting the specifics wrong. There's a huge wad of documents that I need to go back through because I've read all this stuff, but I need to organize it for tomorrow. But basically that would in theory be part of their training.
Oh, so they'd be
Um,
licensed to do that.
to do those things, which again, I think is a little thin. I mean, I'd rather work with a PA, an NP, or an MD who already understood labs and EKGs, than try to do that as sort of an add-on.
And
Thank you.
this brings up a very much related point. And the proponents claim that there's no evidence of adverse events. And it really, it's kind of astounding that they'd assert that, because if a patient died from a heart attack, it's kind of unlikely that a pathologist or a coroner would like say anything more than, oh, this patient died from a heart attack, and like realize that they died from an arrhythmia that was related to inappropriate prescribing of a drug that was known to have that as a side effect.
Yeah, it's also, that's a good point. And it's also similar to the ophthalmologist optometrist thing in that nationwide, there are not a lot of prescribing psychologists. So it would be very hard to have a good data set for that. You would really have had to start gathering data prospectively from day one, saying there's no evidence against doesn't mean that there's evidence for, if you just don't have data.
Well, and a lack of reports doesn't mean a lack of incidents either.
Right. In any field, really. So that's where things stand. And I'm in the process of preparing my testimony for tomorrow morning. I'm just going as, a citizen. If the board did want to reiterate our previous position with a vote, that would be great. I'm having a little trouble. My computer is for some reason going very slowly. So I'm having trouble pasting the emails of the committee members into the chat, but I'll do that as soon as I can get the technology to cooperate. Is there any enthusiasm for a vote, or do people want to leave that up to the individual, or what is the pleasure of the board?
I'd
Any
be
thoughts?
interested in continuing the board's position on not supporting H.237.
Would you like to make that as a motion, Suzanne?
Yes, however I say that, I'm not sure. Yes. I'd like to make a motion to not support H.237.
So we have a motion to oppose. It sounds like Dr. O seconds that. Stephanie, I see your hand up.
I wanted to say the same thing. I think we should take a vote and send it forward.
Okay. And David Coderre, I saw your hand up briefly too.
I agree with those two statements. I don't have to speak anymore.
Okay, so we have a motion and a second. Do we have any further discussion? The motion is to continue with our prior decision and continue to oppose this bill. I'm forgetting which number it was, but
237.
237. Okay. Any further discussion?
I have a question.
Yes.
Is part of the motion to ask Dr. Eiler to represent the board and to communicate its decision?
That was not part of the motion. We could amend the motion to have Dr.
I'm just
Eiler.
wondering, was that kind of implicit, or is that a separate discussion?
I think that's
a separate
discussion.
Okay, all right, thank you.
That's logistics, not the position.
Okay, thank you.
Okay. Any further discussion? All those in favor of the motion, say aye.
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 Any opposed? Any abstentions or recusals? Okay, motion passes.
What time is the testimony tomorrow?
I think it's 10:15 or something. I'm supposed to show up at 10.
And I'll ask David this, but I think it is more than reasonable for Dr. Eiler to say that the board has discussed this and that that was the motion that we would continue to oppose it. Is that correct, David?
Sure, that'd be acceptable, yes.
That would be great. I mean, I think it's best if I just go, as a person, but this is now a matter of fact. And I can, mention that as well.
I think that's
Thanks
more than.
all.
Thank you for bringing
doing
it
that.
up.
I put the state senators who are on the committee that's hearing it, the Senate Health and Welfare, in the chat if people want to send stuff. I sent a short email about the optometry-ophthalmology thing, not identifying myself as representing anyone, but just saying, I think this is not a good idea for these reasons, and send it off.
Great. And I liked your letter, so thank you.
It was very short, but I'm
Short is
told by
good.
people,
Yep.
I'm told by people who do lobbying that numbers are better than eloquence. That 100 people saying I oppose this is better than one person writing an exhaustive and very well researched document about why they oppose it.
Agreed. Okay, let's move on.
Thanks, folks.
David, did you want to go to S142 or S163?
S142, I see Diana Whaley. I'm sorry, Diana, I forgot how to pronounce your last name, but has
Wally.
joined us. Wally is, and she's interested in S142. So, and I had told her we'd be taking it up around 1:15. So I think it'd be good to go to S142.
Perfect.
Hey,
Do you want to lead the discussion, David?
sure. Yeah. Just want to pull up. Take me 1 second to get the next document up. I think my computer caught something from Evans. It's going slow. Okay, so when last we spoke about S142, the board had voted a motion to oppose the bill, and with the busy agenda that we had, a lot of other things to deal with, you did not get into specifics, and so the reason why it was on the agenda today was to discuss it further and see if you would like to have a motion that would add some specific points to the in support of your position of opposing the bill. I sent out a read ahead that listed some of the items that had been discussed last time. Did everybody get that?
Yes.
And so, Matt, if you like, I can go through those one by one, and you can. This is a la carte menu of items that you could choose to include each of the themes, to suggest changes to the whatever the board's preference is. in the beginning, it's the first, there's a list of 6 items that are tied to the language of the bill, and not so much the concept, but just the mechanics and breaking it down step by step and as to how this would work. There's a introductory paragraph just summarizing the history that the board unanimously passed a motion on January 7, 2026, expressing opposition to S-142, which proposes a pathway to licensed physicians who have not completed an accredited training program in the United States based upon having been licensed to practice in a country other than the United States. The main reason the board opposes S-142 is it does not adequately protect Vermont patients by ensuring that participants in such a program have adequate training and experience to successfully and safely practice in Vermont. Specific areas of concern with the program created by S-142 follow. Any suggested revisions to that introductory statement? Okay. And the first point states that and these references are to the bill itself, at page 3, lines 11 through 16, the bill states the applicant has provided sufficient evidence to the board that the applicant has completed a 3-year postgraduate program in the applicant's country of training. This presents 3 distinct concerns. The first is that the board has no expertise even to evaluate the authenticity of documentation that purports to show an applicant has completed a foreign residency. The board is not aware of established entities that might be relied upon to do this. This function is completed by the Educational Commission for Foreign Medical Graduates to confirm validity of educational credentials. There are entities that validate educational credentials, but the board is unaware of any organization with worldwide expertise and knowledge to validate medical residency training documentation. There would need to be a trusted partner established to take on this role. And again, I've looked, there are organizations that offer such a service with regard to education, but I haven't found any that purport to be experts in, what are valid medical residency programs, that they've, have a basis of knowledge about what their documentation looks like sufficient so that they could authenticate it as having come from such a program. I saw Pat raised her hand during this discussion of this item.
David, I'm just, I don't disagree. It's just that in being truthful and coming with all information, what about ACGMI International? It does exist. There are residency programs that are certified by ACGMEI. And I don't know this for sure, but I have heard and read different things that they are potentially going to be revving up this program because of this whole movement. So it does kind of meet that. I don't know that much about ACGMEI, but there is something out there.
I attended a webinar on that about a year, maybe 18 months ago. And they were very, several times they gave the disclaimer that this is not accreditation of programs, that it is for consideration in, I believe it was for readiness for people who are otherwise qualified to participate in a fellowship, I think was what they were doing. But it was really the focus of it was trying to raise the quality of residency training around the world. And it was a really very limited number of programs. And I think I forget how many countries they said had programs participating, but it wasn't very many. It was like a dozen maybe had any programs participating in it. I think it was like maybe I don't recall specifically.
Yeah, you might be right. I do know that that the ACGME has a new CEO within the last year, Deb Weinstein from Michigan, because Tom Naska retired. So there could be that combined with this, this whole movement, can may motivate them to do more.
Yeah. So this first bullet point under this number 1 is really just about the mechanical, not the quality of the program, but just about verifying, like having knowledge about, because I don't know if you're like, I'm on the USMLE committee, and periodically we get the reports about irregular behavior.
I've seen them, yeah.
Some years they come out several times a year. Sometimes they're only maybe every 4 months or so. And they list, and this isn't with USMLE has this very well-developed program and expertise in virtually their network. They have reach into every country that might be sending us medical graduates looking to enter residency in the US. And even with that system and people knowing that, they get people who engage and document forgeries and they alter documents and then get barred. And so this is just about the basic, not about the programs themselves, but about verifying the documentation, which is something that the board would have to take on,
No, I don't disagree. I just wanted to raise the point that there is an organization out there that is involved, and maybe not to the degree and to the expectation that we would have, but there is something that's been around for a long time.
Right. I can add, and especially, that's really, I think, most pertinent to the third bullet point, is that, they're in a sense, they're not an accrediting body, but they are a body that promotes quality. So that would be worth mentioning. Okay, any other comments on the first item? Great. And item number 2, at page 3, lines 17 to 18, the bill includes a requirement that an applicant must have practiced as a medical professional performing the duties of a physician outside the United States for at least 3 of the last 5 years. This assigns the board the responsibility to confirm practice in an overseas setting, which would present an additional practical challenge. How would practice be confirmed? Is a letter signed by a physician on behalf of the applicant's practice site supposed to be adequate? What organization has the capacity to verify the existence of any medical practice in the world or in a region of the world and vouch for the authenticity of the documentation? The board has the responsibility to ensure that applicants meet licensing requirements. Absent a reliable and acceptable means of confirming self-reported experience, the board would not be fulfilling its obligation to protect Vermont patients. I included this in the proposed items because when I went through this and thought about what would the board be taking on? What are the responsibilities? If I were a member of the licensing committee, what would my vote to recommend somebody for participation in the program or giving them a license based on having been in the program? What would that be based upon? And so to me, that's, again, as it says here, that's a real practical challenge. So you get a letter signed by somebody that says they're a physician in whatever, you name the country. How do we verify that? How do we verify that the person actually practiced and understand the nature of that practice? We accept references from physicians when we have an applicant coming here who's been practicing in another state. It's a relatively easy matter for us to confirm that the person signing off on the reference or the name of a reference that's provided to us is in fact licensed in the jurisdiction where the experience is claimed to have been gained. Again, the practical concern here. I don't know if you all think that's also a concern, that you would be in a position of having to say, yes, I believe we have adequate documentation that this person did practice for 5 years in wherever it may be. The third item concerns page 4, lines 8 to 13, where the bill refers to standards for an assessment and evaluation program designed to develop, assess, and evaluate a provisionally licensed physician's clinical and non-clinical skills and familiarity with standards appropriate for medical practice in Vermont, according to criteria approved by the board by rule. And I should note that in some prior discussions, I had said that it would be a long reach for the board to establish those standards. It has the ACOM, the organization that has come together with different stakeholders to put out guidance on this. They have created a toolkit which has 5 pages of suggestions for boards and a document with a framework for the programs. So that would help the board to establish criteria, but still, I didn't bother mentioning that, given that there is something more out there. However, it still remains that there's nowhere in the bill does it say, oh, the board is going to verify that the training is happening according to those standards. And as I got thinking about that, as it says here, nowhere in the bill does it call for the board to oversee compliance with those standards. A set of standards that has no form of oversight is meaningless. And this is just too important to say, oh, we trust every medical practice in Vermont that they're going to do a great job at this. I mean, Mass General is a great institution. They get regularly inspected by the ACGME to ensure that they're operating according to the standards for residency programs. It would be irresponsible to license foreign trained physicians based upon completion of a program and training that is not subject to oversight of any kind. Graduates of U.S. medical schools are required to complete accredited programs that go through regular reviews to verify that standards are maintained. There is no reason to expect less of the programs that would establish eligibility for medical licensure of foreign-trained physicians. Perhaps the lack of a program to confirm program compliance with standards was an error in drafting the bill, or perhaps it was assumed program oversight would be an implied duty for the board. Whichever the case, oversight of training and evaluation programs would be an essential component of the proposed licensing pathway. However, the board has neither the expertise nor the resources to take on the role played by ACGME for existing residency programs. Confirmation of adherence to standards would be essential for verifying both the readiness for practice of those completing the program and the safety of patients receiving care from participants in the program. And I know that many of you are or have been instructors in the residency programs and affiliated with the training program at UVM or elsewhere. That is an important part of it, right? Confirming that the patients who are in the program are getting quality care. Is that a piece of it?
I would say the amount of residency oversight is extreme. In the residencies are reviewed every, can't remember if it's 3 years or 5 years. There's a huge amount of competencies that are involved, both at the administrative level and at the care level, at the teaching level. And the amount of oversight from a residency perspective is huge. There's usually several people involved every time the residency review board comes around, just to make sure they have all their paperwork and everything lined up. The amount of oversight is dramatic.
Does anybody have any concerns or additional comments about this third item? Okay, I'll move on to the next one. Number 4, at page 5, lines 15 to 18, the bill provides that that applicants are ineligible for the pathway if they previously had a license or other authorization to practice medicine suspended, revoked, limited, conditioned, or otherwise restricted on the basis of the applicant's unprofessional conduct. Verification that an applicant meets that standard would present challenges. With approximately 200 nations in the world, how is the absence of disqualifying discipline verified? It would be a significant tasking for the board to overcome the practical challenges of establishing communication with a single country's medical regulators. But applicants might have practiced in many different countries. Across the world's approximately 200 countries, how many have regional medical regulatory agencies, as we do in the US, with each state being responsible regulating medical practice? How many countries have national reporting entities like the United States National Practitioner Data Bank? The International Association of Medical Regulatory Authorities, IAMRA, has established the Physician Information Exchange, but that is a voluntary program, and at present, very few nations participate. While confirmation of the absence of unprofessional conduct would be an essential element of an alternative licensure pathway, this eligibility requirement would require the board to commit additional resources and establish new expertise. Any thoughts or comments on number 4? At page 5, line 18, the bill provides that physicians are ineligible if they have been convicted of a crime. This requirement would present another challenge for the board. Ensure each applicant has a clean criminal history. At present, with IMGs who complete U.S. residency training, this is not necessary because the screening for the J1 or H1B visas needed to train in U.S. programs covers criminal history. And I guess I need to do some more research about I am pretty sure there's no such thing as getting an Interpol background check that covers the whole world. That, as written, the board would make a criminal conviction anywhere relevant. That would be disqualifying. So we wouldn't, again, if we got an application from somebody from Malaysia, we're not necessarily just, concerned about Malaysia or worried about anywhere in the world. And on a practical level, a lot of our IMGs, these are people who are interested in going and living elsewhere. They move around, and it's not unusual to see people who've, been to medical school in one country, trained in other countries, moved around a good bit. So again, just another practical consideration. Any concerns with that one? Number 6, at page 10, line 8, the bill tasks the board with establishing rules, determining which country's licensure or other authorization to practice medicine is acceptable to the board for purposes of provisional and limited licensure. This is important because the safety of Vermont patients would be riding on the adequacy of practice standards elsewhere if foreign training and experience is to serve as a proxy for appropriate training in the U.S. This would present a significant challenge for the board. In addition to the adequacy of the standards of practice, it also involves the legitimacy of the system of medical regulation in other countries. The board would need to determine if a country's medical regulatory authorities are competent, adequately funded, and not undermined by nepotism or other forms of corruption. The board would need additional resources to determine which nations' medical systems operate at a level that is sufficiently comparable to the U.S. system, such that practice there indicates an ability to practice competently in the United States, and whether there is an effective system of medical regulation that can be relied upon to identify and document unprofessional practice. Again, this one, I don't know how we would take this on to say, oh, this country's system is adequate, that country's system is not. I speak as somebody I've lived overseas for 8 years of my life. I've spent 3 years of that time was spent doing international development work, that a big part of it was identifying adequacy of existing systems and identifying the things that really needed to be worked on. It's not easy work. And that was done living in the countries and having huge resources to be called upon, and a lot of support, and the help of the U.S. State Department, the USAID, and other agencies. I don't know how we would do this. And, whenever we discuss these bills in a more general setting, people say, well, other states have done this. I don't know how they're doing it. I don't know how Tennessee is doing this. I don't think it's really happening. I think any state that says this is really happening effectively is kidding themselves. So that I feel pretty strongly about this item. And I welcome any comments anybody may have about that. Right. So
Judy?
at this point, oops, sorry.
I just wanted to
I
thank
just
you,
wanted
David,
to
for
add
how
that I think that, oh, I'm sorry.
Judy, go first, and then Stephanie will get you.
Okay, I'm sorry, I didn't hear that.
Okay. I just wanted to thank David for how comprehensively he looked at this. It was eye-opening to me. And I especially appreciate your looking at the differences in cultural perspectives and the impact that inevitably has in doing any kind of work in a country that you didn't grow up in.
Agreed. Thank you. Stephanie?
I agree with what Judy just said. And also, it appeared to me reading through all of this last night that if the state really wants to open this type of thing up, which I can understand some might want that, they need to almost create another board. With all of the things that David pointed out, they can't ask one small board that's already very active to do all of this. It's just, it won't work. I agree.
Great. Thank you,
Thank you.
Stephanie. David Coderre?
Yes, I appreciate David's written summary that he sent to us before the meeting. It was well written, well argued, and of course well summarized. And I think it reflects our discussions that we've had at prior meetings. This system could well set up a double standard of physician licensure and verification in an attempt to solve a problem that's very real, and that's primary care access in Vermont, which is a huge problem. But this may not be the solution.
Thank you, David. Stephanie, did you have another comment?
No, didn't I? I'm sorry. I tried to turn it off, but I guess I didn't do it.
That's okay. Anybody else have any comments? I mean, I think I'll just add that, David, I really appreciate you being so thorough and going point by point. And, my global perspective, I kind of look at these from the broad view, is that this is an enormous task that they would be asking that I'm not sure can clearly be done by any few individuals, and just not having the access on an international level to get the data that they're asking for. Like, I wouldn't even know how to go ahead and ask for I'm sure somebody out there knows how to get a criminal record from, Egypt, whatever. I find that it's so involved, and there's so much here. And the system that exists in the United States, both for US trained and foreign grads, is already exceedingly thorough. To try and duplicate that system at a state level so that there isn't separate pathways like David was just talking about seems frankly unsurmountable.
I agree.
Judy?
Just one other thought, because I wouldn't want to be misunderstood. I think finding a pathway is a superb idea. I would love to see it done. But it has to be done right, and there has to be the funding in order to make it possible to do it right.
So Matt, did you want me to just finish going over? I got another page here of some more additional concerns that aren't based specifically in the board language.
Sure.
Anybody? Just try and speed it up here a little bit. It's starting on the fourth page. They're styled as general concerns. It says the board understands that representatives from some potential participating facilities, this would be the FQHCs, hospitals, other practices that might participate, have expressed their confidence that they can successfully train and evaluate foreign physicians in a program as described in S-142, and all while ensuring that the patients receiving care are safe and receiving the quality of care they deserve and expect. The board believes that facility representatives may be underestimating the difficulty of taking on all the obligations a facility would bear. Is everybody okay with that?
Yes.
See heads bobbing, thank you. All of the board's physician members have completed residency training. Many of them have been residency instructors and understand the demands on programs. The challenges of training and evaluating medical trainees, all while ensuring patients receive safe and appropriate care, are many and complex. Residency programs receive substantial funding. The amount varies, but it is well over $100,000 per trainee per year from federal funding sources. Now, this is a really, I was trying to get a straight number on this. There's multiple funding sources. The minimum number I saw quoted was 115 to, it had a range of 115 to 155, I think it was. But there's not just a single funding stream. I don't purport to be an expert on it, but I know that 100,000 is a very conservative number of how much money these residency programs get to do these functions. To continue with the text here, virtually every discussion about medical care in Vermont touches on lack of resources and the challenges faced by medical practices today. Taking on the same tasks faced by residency programs without the resources provided to those programs would create strong potential for risk to patients, inadequate training, and insufficient evaluation. Any comments on this paragraph? Everybody on board with that message?
Yeah.
Yes.
One facet of the challenge of being a participating facility that may be underestimated is the degree to which cultural biases and perspectives may play a role. Many physicians who come to train in U.S. residency programs arrive with ingrained cultural biases and perspectives. Different views on gender, gender identity, and sexual orientation can affect patient safety and the quality of the care provided. This is just one example of the reality of training foreign physicians that could demand much greater resources than potential facilities anticipate. Everybody think that's a fair statement? Any suggestions for changing
Do we
that?
have to have ingrained in there? Just ingrained makes it sound a little almost biased towards them.
Sure, I can take that out. I guess I was just trying to convey the idea that a bias like that isn't necessarily overcome with, a knowledge deficit you can fix maybe with, an hour-long conversation and demonstration, whereas biases are developed over years and take more of an effort to combat. Does anybody have any other term they think might work better than ingrained?
I think I understand what you're saying there, but it just taking ingrained. I mean, ingrained just gives a pretty negative connotation in my mind, but maybe I can be convinced otherwise.
Judy's got a hand
Just
up.
say biases.
I had a hand up on something else, but yeah, maybe instead we could, maybe the word assumption could be worked into there.
I think it's okay to just say, take out ingrained and just say cultural assumptions and perspectives. Everyone has those.
Yes.
And one of the things that you do in a residency program is you learn the culture of the place you're practicing.
Right.
That's part of what it's for, is gaining that experiential basis to then go out and practice.
So cultural biases and
Or
assumptions.
just cultural assumptions and perspectives.
Okay,
I think that's fine. I mean, if it's cultural, it implies that it's not a surface opinion, that this is something that's part of how you grow up and what you learn growing up. We all have them.
Yeah. The if we can move on, the other thing that I was considering is if there's a way to add into this that cultural perspectives can be enriching. I feel that what I feel that it's important to say that different views can affect patient safety and the quality of care provided. But I think actually that point will be stronger if we also acknowledge that cultural perspectives can be enriching, which they certainly can.
right. So would members like me to add a sentence that at the same time, the board acknowledges that diverse having trainees and practitioners with diverse cultural backgrounds can be a
Positive.
can support good care, as it can also support good care.
I put a possible sentence in the chat.
Thank you, Evan. And Evan says diverse cultural experiences can also be enriching in patient care. The concern of the board is addressing cultural assumptions as they affect patient safety. Beautiful. Everybody like that?
That's great.
Mm-hmm.
Thank you, Evan.
Okay, I was adding that as a last sentence at the end of that paragraph with ingrained deleted. Okay, move on to the next paragraph, almost at the end here. Finally, when considering the challenges, potential risks, and resources that would be needed for the new licensing pathway proposed in S-142, it is necessary to consider the limited upside. The board understands that there are medical workforce shortages in Vermont and that the shortages are more acute in some regions. Everybody good to this point? However, there are reasons to believe that another typo, I'll delete that S-142 would do little to ease workforce shortages. As noted in an August 2025 guidance document released by the Advisory Commission on Additional Licensing Models, federal immigration and visa requirements and the limited options available to a physician who lacks U.S. residency training will limit the potential number of physicians who might use such a pathway. In the Commission's words, and I think it's worthwhile to quote their words as they are a body that's been brought together with a lot of expertise in the licensing of international medical grads. And I don't know if you all still have that document. I can quickly read it. Furthermore, the ubiquity of specialty board certification is a key factor in employment, hospital privileging, and insurance panel inclusion decisions is likely to impact the efficacy of non-traditional licensing pathways. States may therefore wish to consider other healthcare workforce levers that may be more effective in increasing access to care, such as advocating for increased state and Medicare, Medicaid funding to expand USGME training positions, offering some means of transition assistance to IMGs, and expanding the availability and utilization of enduring immigration programs like the Conrad 30 waiver program, U.S. Department of Health and Human Services, HHS waivers, regional commission waivers, and the U.S. Citizenship and Immigration Service Physician National Interest waivers. Is everybody okay with including that quote? Okay. In addition to ACOM's assessment that programs similar to S-142 are unlikely to be effective sources of licensed physicians, we can look to New York, which has long offered a program of licensure for foreign-trained physicians based on an assessment of education, training, and experience. Just as an aside, the director of the licensing function of the New York board, which is actually part of the Department of Education, did a presentation on this at the ACOM conference or symposium that was held in DC 2 years ago. And I know Stephen, he's on the USMLE committee with me. So I reached out to him to get some numbers, which I just got from him on Monday afternoon. In a state with approximately 120,000 MDs, the program yields about 150 to 175 licensees per year. Vermont has approximately 6,000 licensed MDs, about 1/20th the number licensed in New York. And at this, I'm going to throw in a comment that New York has, its last time I checked, is just over 40% of all the physicians in New York State are IMGs. In Vermont, we run about 28 to 30%, which is a fairly significant differential in the, it reflects, a presence of many people from all over the world in the medical workforce that Vermont just doesn't have. And I think that, we that's just a factor to consider when we look at their numbers and think, what's our uptake going to be here? Even ignoring the fact that New York has a much more internationally diverse population and a significantly higher overall percentage of physicians who are IMGs than Vermont, the New York numbers suggest Vermont would gain no more than 10 licensees per year. And I think that's really, I think 10 would be very high. Even having 10 participants, much less people who successfully completed. I don't know. I just threw this out there because I thought it was important to put it in perspective. New York has been doing this for about 20 years or more, and they devote a huge amount of resources to it. I could share a slide with you. It's a 7-step process that includes different boards and committees and staffs in the education department and the medical board and Rick, Pat, were you present at the ACOM meeting in DC?
No.
Yeah, I mean, Rick and I were sitting next to one another at it, and I remember we were doing the math on the back of a napkin at that meeting, and we were saying, well, this could be maybe 5 a year at the most. I don't know if you all
Yeah.
think it's worth mentioning this.
Hey,
I mean,
David.
and in terms of the numbers, New York, I mean, it's a huge state. They have really 2 and actually 3 boards because that take the place of our 1. They have a separate licensing board.
Right. Yeah, they have a licensing board and that's part of the Department of Education. And actually, the Department of Education plays a key role in this process for evaluating the training and education. And they have a whole division within the Department of Education that does that.
Hey, David.
Yes.
In talking to your friend, your acquaintance there, a couple of questions came to mind. One, did you ask about how many hours per licensed physician the process takes, or how many dollars per license it takes?
That we asked that at the meeting, and I think it was actually a conversation after the presentation. Rick asked him, and he said they don't have firm numbers. It's a ton of time. He said, and he only knows what happens within his scope of within his office. And again, I could find the chart if everybody wants to see it and pull it up. It's a 7-step review process that goes all around and through a couple different arms of the New York State government.
Did he mention whether they've had any misses, people that have made it through that in retrospect, or had problems later on down the line that in retrospect shouldn't have made it through? I mean, it sounds like it's a fairly robust program.
Yeah, that didn't really come up. I mean, we were what we were mostly discussing was, because Rick and I were trying to get a handle on, well, how would this actually work? If you're evaluating their practice and we walked away with a sense that there weren't really meaningful criteria. There's sort of like a list of items that you look for, but it wasn't it wasn't like like if you took out ACGME standards and they defined all kinds of functions and the standards that align with each of those functions, and it's not quite like that. It's kind of just like, well, people read it over, and if they have a good feeling about it, then they move it along.
Yeah. I'd be curious to know if they would put a number value on it, say if another state wanted to outsource their program and hire the New York program to do their investigation work, if they would be willing to put a number value on what that would cost.
Yeah. I'd ask them, but I don't think that's a thing.
Well, I mean, they have the infrastructure. If we rely on other outside agencies to do the basic screening of our in-state, of our own national grads, then, if there's an established organization that has a process and is willing to do it without recreating the wheel, I don't know. Just a thought.
Yeah. So how does everybody feel about keeping this paragraph or something that looks like it? Any suggestions for changes to it as it's stated, if you do want to keep it? So maybe, so I don't hear any so my list of things that I was going to do. I made most of the changes that we've talked about along the way. I need to go back and come up with a statement about CME, which is a program of ACGME to foster improvements in medical residencies around the world. And I could make, I mean, there's two ways we could go. One is I could ask you all to if you want to have a motion adopting this subject to me adding something like that. Or I could, while we're in executive session discussing cases, I could work on that, and we could come back and I could run wording by you at that point.
I think either is okay. You know, we can endorse the concept or we can hear the language. Sorry, Gail, your hand popped up just as my mouth was going, so go right ahead.
You're on mute, Gail.
I would move that we accept the proposal and authorize David to make changes in line with the discussion. I don't think we need to go back and line by line it again.
So we have a motion. Was that a second?
Yeah, that was a second.
All right. So we have a motion, we have a second. Do we have any discussion? David, I see your hand up. David Coderre.
No, that was a second.
There's a second.
Second.
Any further discussion? I think we've talked about this a lot. There's a lot of detail. There's a lot of nuance. There's a lot of concern, obviously. I think that in general, yeah, we'd love to be able to have more doctors and put people that were doctors back in their line of work. It's just making sure that we can do that safely is going to be really, really difficult.
And with available resources.
And with available resources, yeah.
For such a small yield.
Yeah. Very
and
true.
Considering that there's other pathways to get more doctors.
If New York State wants to take this on for the country, I would heartily applaud them.
Okay. Any further discussion? All those in favor of the motion as it stands, say aye.
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 Any opposed? Any abstentions or recusals? Motion passes unanimously. Okay, let me go back to my, where are we?
We're at S163, unless do you want to give people a quick break?
Everyone.
Thanks, Diane. We'll see you.
Do you think this is going to be lengthy or? Why don't we see if we can get to it and then we'll take a break before going into executive session.
Okay, yeah, we'll put it in overdrive. I'll just, so S163 is a bill that says, right now, there's a law in Vermont that provides that each hospitalized patient shall have an attending physician who is responsible for coordinating a patient's care. And I just noted in the that with regard to this issue, CMS regulations for requiring a physician in this way or allowing an APP to be in that role depend on state law. So in other words, if Vermont says that an APRN or a PA is okay, then that's good enough for CMS for billing purposes. And I've watched some of the testimony on this. You know, APRNs are saying oh, that, I really, there's one person who was a certified nurse midwife, said, when I have a patient who's having a baby, I do everything. It's only if there's complications and the OBGYNs get involved, when it's not just me, that this will simplify things, because there's just, one person on coordinating the record and the admission and the discharge. This would be great. There are a number of states have moved in this direction. The proponents of it testified that New Hampshire does allow it, and I went to go confirm and see if that was true. I couldn't find any, which is kind of something borrowed from the CMS regs, and it's defined to be a physician, or APRN or PA, basically, or podiatrist for patients that are there for podiatry care, that kind of thing. I don't know if members, I just put this on there to see if members have a strong feeling one way or another. They reached out to ask me to testify as a director of hospital licensing, and the Department of Health said that I wouldn't be testifying on it based on hospital licensing concerns. And so I just put it to you to see if there's any concerns among members here, if you would want the board to get involved on this one.
I see several hands up. Why don't we go in order, and then I have a comment myself.
And I don't want to interrupt you, but just and the last piece that you make, so everybody have a chance to know what I'm about to say when they're making comments. Yeah, my other question is, if they're going to change the bill and you're okay with them making it APRNs, do you think that that should also include PAs? I'm sorry, Matt. Now I'll be quiet.
That's okay. Suzanne, you're first.
Okay, so I do have some comments. I know everyone's really tired, wanting to take a break, but I have been emailing and making some phone calls when I saw this pop up. So in Vermont hospitals, PAs and APRNs admit and manage patients every single day. The Bill of Rights, as David said, says that you have to have a physician to serve as the attending. They have to sign the admission and the discharge plan before the patient can leave from an inpatient stay. There are delays when a nurse practitioner or PA cannot find a physician, and the patient may not go home that day. They may not be transferred to rehab. Obviously, if they don't go, that increases the costs and takes a bed from another patient. On an outpatient level, PAs and APRNs, they are trusted to independently manage patients in primary care and specialty practices. So the current Bill of Rights is inconsistent in that it restricts them from being recognized as a admitting provider. Obviously, Medicare A, I think David touched on this, requires a physician to be listed as a billing for billing purposes. But it would be very good if Vermont recognized PAs and APRNs as the admitting provider for regulatory purposes and clinical accountability. It does happen in other states. I tried to get some examples from Vermont PAs, did hear about a specialty PA trying to get discharge a patient, but the provider was stuck in surgery. So surgery went late. This happens a lot in the PA, and the patient does not get discharged. Another example, which is a little scary, I think it was medicine inpatient. The PA will walk around till they can find a physician because they've been taking care of the patient the entire time to try to get them to sign the discharge, which slows things around. And then that provider probably wants to go and see the patient because they haven't been involved in their care, and then they have to put a signature on there. So I don't think it's a safety issue. And we also have to remember that hospitals do have very strong credentialing and bylaws to manage the PAs and the APRNs. My conflict with this is that Since the fall, the Vermont PA Association has been trying to work with the nurse practitioners. Initially, they agreed to include PAs. Some of the PAs behind the scenes also helped rewrite the Bill of Rights that would include both. But in the end, it is my understanding that the APRNs have decided they do not want to include the PAs. They also have more money, I think, to put towards this. So just my opinion. Thank you.
Thank you, Suzanne. Evan, you're next.
I'm concerned with the global nature of this, in that the midwifery example is particularly problematic. In Quebec, a few years ago, nurse midwives won legally the right to practice independently, but were unable to exercise that right because the insurers said basically, the reason that your malpractice insurance rates are affordable is because you have these close relationships with the obstetricians, and they're obligated to step in when your case becomes more complex. And if you sever that relationship so that you have to seek them out as a consultant and there's no automatic obligation, then you're essentially taking on the responsibility of the obstetrician and will need to be insured as such. Where I'm going with this is, I'm listening to this. We're talking about a lot of bills today, and I'm sort of listening to this going by. And when it got to and a nurse midwife testified, and she said, we do it all and we don't need the obstetrician. Like, I think that's really a very superficial take on it. I mean, over 20% of deliveries go to cesarean. So anyway, I'm just saying, I'm concerned on two levels. Number one, if we're going to do this, throwing the PAs out is ridiculous, and sounds to me like a political power play on the part of the MPs. Number two, I'm concerned about the breadth of the assertion. So would not support as written. Let's put it that way.
Thank you, Evan. Ian?
So my first question, when they say role, what's the definition of the role they're talking about in the hospital? Does it just have to do with just a discharge, or what other roles are they talking about? Because pretty much, Susan, you guys do everything correct in the hospital?
There has to be an attending or a physician, MD or DO, that signs I believe admission, but I know the discharge.
Yeah.
Like there at Rutland Regional, there is either a nurse practitioner or a PA that their only job is to admit patients. And then they have to find, then they get admitted, and who knows who they go to. And it probably goes down the road to who gets the signature to get them out of there.
Right.
That's my understanding.
Yeah. I think from my perspective, I would be okay with the PAs or the advanced nurse practitioner signing the discharge or the admissions without the MDs or DOs, because you guys do everything outpatient anyway. So I think I would be okay with that. With regards, Evan, with regards to the midwife, how much role did the midwife come into do they come to the hospital, the midwives?
They do on complicated deliveries. If difficulties arise, then they have relationships with obstetricians that currently there's that link that they have to be working with an obstetrician.
Don? You're muted, Don.
Thank you. I'm sorry about that. So I have two brief questions. Suzanne, when a PA in the hospital has to find a physician to sign a discharge order, is there an extra charge for that brief intervention or action?
I can't answer to that because I think the billing goes through the physicians.
Okay. All right.
I don't
Am
know,
I,
but I don't think so,
sure that-
unless that physician then decides to try to bill to go see the patient, but I don't think I don't know.
okay, it just, it's efficiency and cost I have in mind. So, do you know what the issues were among nurse practitioners to only, beyond political, did they articulate their rationale for opposing PAs doing this?
I think it makes the language more difficult. And I think they figured it would be passed easier if they were just themselves.
Okay, thank
They
you.
want to fight their own fight, I think.
Okay, thank you.
David Coderre?
Yes, I think this is the most far-reaching issue we've talked about today. I think this is potentially has the most widespread effects on the health of the public. And unless there's some reason we really have to make a decision about this today and have time to really get into this, I think we should deal with this at another time. This is about accountability in my judgment. Somebody has to be accountable for the care of a patient in a hospital. At the hospital in town here at Copley, there are primarily PAs and some nurse practitioners that do admissions and discharges, but the physician hospitalist, generally it's a hospitalist, is accountable and knows those people and doesn't have to, if they're asked to sign something, doesn't have to run around and acquaint themselves with the patient. At least that's my understanding of the way it still works. So this is a big deal. The difference between the hospitalized patients and the ambulatory patients is, in general, they're much more complicated and obviously acutely ill. So it's a big deal and needs a lot of discussion, I think.
Ian?
So, Susan, one last quick question. So if the advanced nurses drop the PA, are you guys going to take up your own bill, or what are you guys going to do, the PAs?
I asked one of the PAs that, and she said they didn't know at this point.
David Hurley?
Yeah, I just want to address David's point about, is there urgency to do this? It's going to be discussed tomorrow. Jessa Barnard and Devin Green from VAS are on the schedule to testify. I don't know if it will get passed out of Senate Health and Welfare tomorrow or not, if they're going to vote on it. I don't think it's scheduled for a vote. I don't see this going through this, getting out of the Senate at this point in the year in less than a few weeks. Then it would have to go to the House. We could discuss it next month, as David suggested, and you could do a deeper dive on it, and it probably would be timely to be able to be part of the conversation in the House.
Yeah. David, did you have another comment? Coderre? You're muted, David.
Briefly, sorry. Yeah, if there's a discussion tomorrow, I think obvious questions are, what does the hospital association say about this, and what do the insurers say about this? Those would be really two key voices to hear from if I'm a legislator evaluating something like this.
Yeah, I think that's a really good point. I just wanted to make a comment. I've heard a lot about this bill. There's been a lot of back and forth between some of the medical directors in the state. Devin Green sent out a big post about it, and there's been a lot of conversation, and there's really strong opinions on both sides and big effects on both sides. Some of the critical access hospitals, this could be a lifesaver for them to continue an inpatient unit where they can't staff a physician due to costs. So there's access questions, there's cost questions, there's quality questions. It's like all the other scope of practice discussions we've had earlier today. And I have to admit, personally, I kind of have not made up my mind on this one. I think I could go either way. I think there are, I think if you look historically, the difference between a physician and an APRN or a physician assistant was there was more difference than there is currently. I think that in many other roles, nurse practitioners and PAs are, if you look at them in the outpatient clinic, they're considered equivocal or equivalent to a physician. And I think this is the step to doing similar on the inpatient unit. Now, that doesn't mean that every hospital would go along with the process and could choose to continue to have, a physician signing off. And, personally, I think the APRN/PA with physician team is probably the best model out there where they're working together. But, this is, things are changing. And I think that especially at the critical access hospital, this is a huge issue for them. It does also bring up the questions, as somebody pointed out, the insurance. And, my guess is that if an APRN is signing off on a chart as the primary without a physician, their malpractice is going way up. Because right now, when you have a physician signing off, then, if there's something comes out of it as a lawsuit, they tend to go after the physician because the physicians have higher coverage. So I suspect that this would be the start of a fairly big change in both hospital credentialing, hospital practices, and insurance and malpractice. But it's really complicated, and there's a lot of cost analysis that's involved in that. So I don't know. I have not made up my mind on this one. I think that I know some exceptional APRNs that I would absolutely just let them run, and if they felt they needed a physician involved, give them the credit to make that decision. It's a tough call in my part, but I see a lot of other hands, so I'll stop talking. Dawn, you're next.
I've lost my train of thought. Could you give me a minute and come back to me, please?
Let's go to Evan and we'll come back to Dawn.
All right.
Sure. I would like more information. The midwifery part really caught my attention. That is concerning to me much more than many other not quite so acute aspects of care, but I just would like more information. I don't feel ready to vote in either direction today.
And I don't know that changing the midwifery role, again, it depends on how your hospital is set up. The way we work, if the midwives can handle the course from A to B and the baby's delivered and there are no complications, then there probably doesn't need to be a physician involved. But as long as they're working hand in hand with a physician, so if something does go wrong.
That's the difference. That if you have a relationship that's set, the physician has to step in.
Yeah.
And if that relationship is severed, then they kind of don't.
Yeah.
But anyway, I would like more information. I don't feel ready to vote to endorse or to oppose. I also will just mention that the question, if we circle back to this, I have the answer to the question about psychologists and what drugs, if we circle back at some point.
Okay. Let's go on to Pat, I think, next.
Yeah, I just, Matt, I was intrigued by something you said, and that is that the critical access hospitals would staff with an APP, whether it be a PA or an APRN, due to the lower cost and not due to unavailability of MDs or DOs. So that, if that is the case, that really is, this change could completely change the workforce in hospitals.
Yeah.
completely.
Well,
And-
some of the workforce is that if you're at a critical access hospital and you can't maintain a physician, then you wind up going to a locums physician, which is even that much more expensive.
Yeah. No, and that, so I understand all those things, but I think, there's a lot of unknowns here, a lot of unknowns. I would agree with needing more information and kind of getting a better lay of the land. I would suspect that VMS has been following this. I would be curious to know where they stand and what position they are taking.
We'll all find out tomorrow, or it will be known tomorrow. I can
Okay.
send out follow-up and the link if you're interested in watching it, and also the link to when the APRNs testified.
Mhm.
Gail?
Yeah, I mean, I'm hearing all this, and these are really new issues for most of us as board members. So I would move, if that's appropriate, that we continue discussing this at the next meeting and not try to force ourselves to make a decision today. But it does sound like a very important issue to address and get much more input on.
Agreed. Dawn?
So, thank you. Sorry, I lost my train of thought. I'm just thinking strategically, it's hard to know who the committees of jurisdiction, if they're really wanting to push this. David, maybe you have a sense of that, but in terms of whether or not it's timely for us to make a decision about this, I'm wondering if there's any chance or risk, David, that if it doesn't come out of committee, that it could be pushed and tacked on to the annual OPR bill. And that we might miss a chance to really weigh in, because sometimes that happens pretty quickly.
I'm not sure about that.
Because it's germane.
It probably meets the bare minimum for being germane. The whether they do it having proposed it as a freestanding bill, I don't know. And it's been, taken up quite a bit in committee. A lot of people interested in it. And again,
Okay.
this was just introduced in January.
Yeah.
So again, I don't, it's pretty fast.
Yeah.
I don't know how quick they're going to move on it.
Okay, thanks.
So I think just to round things out, this is a really complicated issue. We all want more time and more information. So maybe, David, you could put together a little bit of an educational packet for us before next meeting, and we can consider it further. And Evan, I see your hand up again.
Would anyone like the answer to the question about which drugs?
I would.
Yeah, I pulled up the bill as passed by the House, which was, we're in the biennial thing. So this was passed by the House last session, and last session, the Senate Health and Welfare didn't advance it. And now it's back in the Senate Health and Welfare. And so the psychologist has to have a collaborating practitioner at first, and it says that the psychologist may prescribe medications schedules 2 through 5, which is basically all of them. The only things that are Schedule 1 are research drugs and substances of abuse, like heroin and Quaaludes are Schedule 1. None of us have Schedule 1 licenses. So any Schedule 2 through 5 substance, except for injectables, and they shall include only prescription drugs for the treatment of mental health conditions that the collaborating practitioner generally provides to patients in the normal course of practice. So that would include things like alpha and beta blockers that, I prescribe those for mental health reasons not uncommonly. We're not just talking about sertraline or something like that.
So it's psychotropics plus.
It's any medication that you're using for a mental health reason. So that, like, if you're giving something that was developed to be a cardiac medication, but it can also be used to treat panic attacks by keeping the heartbeat slower and more regular, then it becomes a psychotropic medication.
Yeah. Wow.
And substance abuse would not fall under mental health.
I think it does.
Because that
And
gets
it schedules 2 through 5.
Because that means you could get a psychologist prescribing bupe for.
I think so. I'll put the reference in the chat. Someone else may read this differently than I did, and if I'm being overly cautious, then someone else can take a look at it and correct me. But it sounds to me like it's very broad, since it doesn't mention substance abuse specifically, and substance use disorders are mental health disorders, then I don't think they're excluded.
Yeah, I think I'm sorry to jump in, but I'm pretty sure, Evan, I saw there's somewhere in the definitions, they tie it into anything that's in the DSM-5 or whatever.
Which would include
current
substance use
references,
disorders.
Right, yeah.
Okay.
Yeah.
Interesting.
So, but someone else can take a look. Maybe I'm being too broad in my interpretation. But anyway, there's the reference in the chat.
Okay. David Coderre?
Yes, I looked at the bill too. I agree. I think Evan's right. It's quite broad. It does involve the DSM definitions of diseases. The collaborating practitioner needs to be a psychiatrist, and basically the psychologist can prescribe anything that psychiatrist, the collaborating psychiatrist, prescribes. There's a couple of peculiar things. Postdoctoral requirements for rotations in clinical rotations like family medicine, geriatrics, internal medicine, and pediatrics are. I think there's a 14-month. I don't know how that happens. I have no idea how that would happen. And I think there's also an exam or something in psychopharmacology that they're required to take. But yeah, what I see is basically what Evan is summarizing.
Wow. Okay, well, thank you for sharing that. That's helpful. Why don't we call it there? And I'd like to go to take a motion to go into executive session and give us a pause and get back here by 3 o'clock. Does that sound okay to everybody?
So moved. Philibert.
I heard Philibert. Do we have a second?
Second.
Eiler. Excellent. Any discussion? All those in favor say aye.
Aye.
Aye. Any opposed? Okay, we'll see you on the other side at 3.
Nope.
I feel like we had 18 before. Oh, that was before Pat left, though. Okay, I think we got everybody back. Let's see, we started with North.
So you want me to go ahead?
Yeah, why don't you go ahead, Judy?
Okay, North recommends 2 cases for closure. The first one is MPN 170-1225. Recommend closure with a letter 1. The second one is MPN 148-1025. Recommend closure with a letter 1. That's
All right.
it for North.
Okay, and do we have a motion to accept those recommendations?
So moved, Chapinelli.
And a second?
Second, Jones.
And any discussion?
Wasn't 170-1225 a special one?
Well,
Yes, it was.
you know, I asked Pat that because I thought it was a special one too, but she said, no, it's just a letter 1.
That's what she
Right,
said.
but I think he's referring to my case.
Yeah.
Which is a special one.
Oh, it is a special one. Okay.
Yeah.
My mistake. Thank you for the clarification.
Nice catch, Scott. Thanks. Okay, any further discussion on that? All
Just
those
for the
in favor?
record, I have Kader recused on 148-1025, and I have Greenberg recused on 170-1225. Correct?
Yes. Thank you, Ron.
Thank you.
And all those in favor say aye.
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 Opposed? And we already have the recusals. Thank you, Ron. Okay, Gail, Central.
Central has 2 cases to recommend for closure. MPC 144-1025. We recommend a special letter 1. MPC 156-1125. We recommend closing with a regular letter 1.
And do I have a motion to accept those recommendations?
So
Motion to
move,
accept,
Philibert.
Tucker.
I heard Philibert and Tucker second.
A second, yep.
Any further discussion on those? All those in favor say aye.
Aye.
And just to be clear, that should be everybody except the Central Committee voting. And any opposed? Excellent. And I think there were no recusals, but anybody else that's recusing, please send that to Ron. And then finally, South, Suzanne.
Yep, South has 1 case that we're recommending for closure. It's MPS 153-1124 with a special letter 1.
And do we have a motion? Again, excluding anybody from the South Committee.
So move, Philibert.
And a
Second, Kader.
Perfect. Any further discussion on that case? So those voting not from the South Committee, all in favor say aye.
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 Any opposed? And any additional recusals to Ron? Okay, that sums up our executive session. And I think that sums up our meeting. We had is there anything else on let me go back to the.
Matt, I just wanted 90 seconds.
Please.
Just to point out a couple things. I sent out the list of bills. Hasn't come up yet, but there's one H581, which is an act relating to limiting the reporting of certain medications to the Vermont Prescription Monitoring System. It would exclude prescriptions for controlled substances that are prescribed for the purposes of reproductive health care services or gender affirming healthcare services. The only one I know of is likely testosterone.